So I'm Zulfiqar Bhutta, Zulfi Bhutta to most people. I'm the founding chair of Women and Child Health at the Aga Khan University in Karachi, Pakistan. And I'm also the inaugural chair designate of the Center for Global Child Health at the University of Toronto and Sick Kids. I've spent the last 25 years or so in Pakistan largely building a research enterprise that focuses on knowledge synthesis, on generation of information for policy, but also importantly on implementation and implementation research for scaling up. So our research spans the continuum of generation of ideas and then working with policymakers in ensuring that they are implemented initially at a reasonable level to give you a sense of confidence that they would work. And then once you are confident that interventions, and particularly interventions that target the poor, have a reasonable chance of being scaled up in the health systems where they matter. So most of my work in the last decade in Pakistan and in other parts of the developing world has been on this interface of research to policy, and particularly research that impacts on reducing inequities. The burgeoning population today largely lives in rural areas. It's about 60% or so of the population. There is also a demographic shift with people moving to cities. And the health and nutrition indicators of the country, if you just were to take one measure of development, are amongst the worst in the world. So we are still faced with an enormous challenge of high rates of maternal and child mortality, of rampant undernutrition, of services don't quite reach the poor and people who live in geographically difficult to access pockets of population, rural as well as urban squatter settlements. But amidst all of this are also people and institutions who are trying very hard and frequently successfully to make a difference. So Pakistan also has some of the most interesting innovations in the private sector or non-governmental space on trying to provide access to people in emergency medical care, transportation. It also has some very active social enterprises around microcredit, trying to reach poor women in rural areas, and was one of the first countries in the world to actually implement a community health workers program for women, largely reaching the poorest populations in rural areas, which otherwise people don't have access to qualified health care. Community-based interventions encompass a range of things that happen at community and household levels. So at the one end, they could be just simple interventions that relate to supporting communities, women as well as men, in organizing themselves around support groups and creating the environment where people have the ability to sit together, plan, prioritize their own problems, and sometimes work on indigenous solutions. Then you can add on to this a layer of outreach workers who are frequently people selected from the very communities themselves, who then work with those communities to implement simple preventive, promotive interventions. Things like educating women how to look after small babies, how to look after their own health and nutrition during pregnancy or during reproductive age. And then in an increasing level of complexity, there are also challenging interventions to layer on top of all of this therapeutic interventions, things that you can actually do for illnesses and also for curative services where people do not have access to alternative methods or traditional health services. So this entire potpourri of what is now called community delivery platforms includes a range of promotive, preventive, supportive, and rehabilitation services. So one big challenge that we have at hand in Pakistan, as well as in other geographies, is how could you optimize the mix of interventions that are delivered by these services, and also do this in a manner that this is not the ceiling, that you use this as a transitional step as you develop much more sophisticated linked health systems with the link between primary and secondary care. Well, I mean, there are many benefits, as I've already alluded to, but I think the most important and perhaps the one that people are most fascinated by focus of these community interventions and delivery strategies is the ability to reduce the inequities, the equity gap, so to say. So for many of the interventions, particularly those that relate to interventions around maternal health, newborn health, it's very clear that the gap between the haves and have-nots, the gap between the rural and urban populations, even within urban populations, between those who live in urban slums and other well-privileged locations, the gap is huge. And to reduce that gap in a reasonable period of time, these community strategies or community-based approaches are the most cost-effective, expedient, and well-recognized way of doing so. And that's the attraction of this to policymakers. Well, technology has a major contribution, and particularly information technology related to cell phones has the unique opportunity to reduce the information divide and also provide access and opportunity to people. But it has to be used judiciously. And at the end of the day, one has to recognize that a cell phone has limitations. I mean, you cannot do a cesarean section with a cell phone. So therefore, one has to have a very balanced approach of using the information technology to empower health workers, empower communities, create demand, support demand creation in manners that otherwise mass media would not be able to achieve, and to couple that with quality services. So the imperative of the so-called M-Health or some of this technology revolution is that it should not lose sight of the importance of quality services. What's the point in creating demand if you don't have anything to fulfill it? It sometimes backfires on you. So I think it's important to have all of this in the context of how services are delivered. But having said that, in Pakistan, the Lady Health Workers Program or this Community Health Workers Program, virtually 90% of all of these health workers have a cell phone. And that's not been provided by the state. So people are already moving in a direction where you don't have to buy shoes for people because they will wear them because they want to. So information technology has its own pace of permeation and also reaching people, and we need to occupy that space with quality services. That's an area that we have worked extensively on. So there are traditional and scientifically proven ways of looking at some of these outcomes, which on the quantitative side mean that for the outcomes that you and I are interested in, mortality impact, morbidity impact, does it impact on process pathways, hospitalizations, care, and curative services? Do these interventions all equate? Do they work in the same direction? Can you undertake meta-analyses to see their impact? And all of that work has been done. But sometimes these scientific methods are inadequate to measure some of the impacts of these community interventions that are more difficult to quantify. For example, how do you measure empowerment? How do you measure the fact that many of these community delivery strategies and approaches actually empower women with greater dignity? Those kind of measures require an approach that has to be a blend of the quantitative and qualitative. Sadly, the information and data around that is much more limited than the quantitative side. But we are beginning to see assessments, and we're beginning to see qualitative evaluations that encourage us greatly that these interventions also have the ability to reach, empower, and reduce some of the barriers around women's rights and status in society.